Okay. Hello, everyone. I'd like to introduce Russ Dunning. Russ is an accomplished sports physical therapist, strength coach, and researcher who comes from a background as a martial arts and strength athlete. After his academic years, which include a Master's of Science in Biomedical Engineering and Physical Therapy, he pursued becoming a strong first kettlebell instructor to complement his sports medicine physical therapy focus. As an academic, he is published and active in research. And as a physical therapist at Chyme Performance Physical Therapy in Sacramento, California, he is deeply involved in his patients' successes. And as a coach, he leads groups of both young and professional athletes to better their total body performance, strength, and conditioning. Russ is the sports medicine coach for the UFC Hall of Fame, Uriah Faber, and Team Alpha Male. Please welcome Russ Dunning to talk to us about sports physical therapists and their integral part on the rehabilitation team.
Cool. Thanks, Jenny. All right, guys, we're going to begin here. We are talking about really physical therapy, but I think at the heart of PT is the art of programming. At least that's probably half the battle. The first half is, can we understand what's going on with someone, of identifying why they hurt? And the second half is how to induce change, how to help adaptation and create a long-lasting effect in the human body, both for health, safety, and performance. So from a grand standpoint, that's what we'll be talking about today. I am getting more used to virtual presentations, but I don't think you can do physical therapy or any kind of workshop in my space without getting up and moving around. So we are going to have a lab portion. For any of you listening while you drive or sitting in a space that you can't work out, well, so be it. But for those who are willing to attempt, we're going to do a few lab activities to make it real when we talk about program, specifically how to stretch the body, how to activate, how to enhance slow tension, any number of those things. So I think I have my chat function turned on. Maybe Jenny, just go and interrupt if there's a question, okay? Okay, so that's me. Here we go. We're going to talk about progressions and exercise programming. So when I say client retention, it does mean patient retention. It means, can we evaluate someone and have them come back? No matter what type of patient I'm seeing in physical therapy, if they're a patient of mine and they're coming in for a problem, it's very rare for me to see them once and say, you are good to go. All I need to do is see you once and you're addressed. The problem's fixed. You'll be on your way. That's extremely rare. So when we say client retention, we really mean what's going on with the body? How long is it going to take to induce change? And can I help retain you through that time period to teach you all of the skills you need to help your body improve? Now, notice that could be 2 sessions, it could be 5 sessions, it could be 30 sessions. It's not about retaining them for a certain amount of visits. It's about retaining them for a length of time in their journey that allows them to be a different person that's a new and improved version of themselves. So sometimes I see people once a week, sometimes I see people twice a month. Every now and again, I get an extreme DIY type person. I give them the drills to do, I see them monthly. But we need some interaction to kind of teach them what we know about the human body to affect change. Now, to affect change, that is safe progressions. Rep schemes, duration, load, that's smart programming. How we influence them with motivation, that's coaching. So how to identify a safe progression? Well, safe progression, I think a great word would be appropriate. And appropriate for who? So recognize, depending on the person, they might be a hyper or hypomobile person. They might have high kinesthetic intelligence or low. You have to ask yourself, do they move like a giraffe? Do they move like a stiff board? Do they move like a supple leopard? There's like a lot of animalistic, natural type ways we can describe the human body. But if I say, can you touch your toes? Are you able to do it with grace and with smoothness or not? And so a big part of what we need to work with is, what is the natural neurological kinesthetic IQ of that person? Or someone coined it KQ, the kinesthetic intelligence quotient, which I think is cool. IQ, EQ for emotional intelligence, KQ. I think it's a good way of looking at it. Recognizing different body types, we can also recognize some people are more apt to strength or power. Some people are more apt to endurance activity. So I just did a little research study, just a research review a few hours ago in preparation for this, and I found that in a normal adult, the growth hormone variance across population could be 14-fold for women, 25 for men. That's extraordinary. That means when you're dealing with someone and you give them an exercise, you might have a 25-fold difference in how they respond to that exercise, how they might respond to that load, based purely off of a hormonal standpoint. Now, 5 times for youth are obviously blossoming with growth hormones, how they grow. So when we're dealing with someone, particularly to the ages of say 10 to 15, there's less variance. They're all growing a ton. But as we leveled up with growth, just recognize, are you dealing with a super adapter or a slow adapter? And that might dictate how slow you go with your own programming and how much time it takes. You kind of have to size someone up to some degree. What's the size of their muscle? What's the size of their bone? What's the size of their joint? How tall are they? But also their history with the body and what they've done with it and the successes they've had with it. So recognize all these factors matter when we're looking at helping someone adapt to change. The other components that really matter are lifestyle, history with the body, and where they're at in the continuum. Those are critical. You know, for us to influence people, we have to get to know them. It's what makes this job so fun. It also makes us quite durable. We're always going to be needed in the world because from what I've seen, great coaching and accountability matter for how people adapt. So understanding people's life, the ins and outs, the struggles, sleep problems, what's their environment look like? Don't have them do a full exercise. If they have three puppies on the floor, they can't get shit done, you know? Do they have 2 kids that they have to get up early for? Are they sleep deprived because they're caring for a sick person? Now, all of those things matter in their own environment. So we have to create programs that fit for that person's lifestyle and to some degree, even like personality. In understanding safe progression, we also need hyper focus on intent. Where are they at along our performance continuum, which I'll show you here in a second. And then we also have to identify a benchmark for success. I'm amazed how many people come into me and ask this simple question: Russ, have I improved? Now, they might intuitively or unintuitively understand that they're actually getting better with exercise, but they look for our feedback to say, yes, you're moving better. They need faith that they're traveling along the right journey, the right plan, and their trajectory is where they want. And oftentimes, if they have a functional pain pattern like walking downstairs, walking down a hill, going for a jog, maybe they don't try those activities all the time, and they're looking for some map of like, am I getting better along your benchmark system? And so it's critical to have benchmarks along the entire journey to help retain them, to help them stay connected to the journey and help induce change. So the basis of focused intent. What are we programming for? And you know, for the doctors that are listening to me right now, either you'll be involved in rehabilitation on an osteopathic level, meaning, you know, manipulation, mobilization, or you'll be involved from a referral standpoint. You're going to refer, you see a diagnosis and refer to PT for change. The key thing that any PT is going to ask, and that you need to ask as well, is what are you programming change for? Is it for movement? Otherwise, mobility? Mobility where? Is it in the deepest structure? Is it at the articular cartilage, synovial fluid, joint capsule level? Pretty deep. Is it more at the muscle tendon, the connection to the next muscle, into the next muscle, into the next muscle? Or is it the more superficial connective tissue, the fascia? Is it movement? And let's be clear, what movement is it? Is it stamina? Now, I know it's pretty unreasonable to say, I'm going to do a little biopsy of your gastroc and your soleus, and we're going to see how much mitochondria you have in that muscle cell. But we can perceive it with some holds, with some exercise tolerance. And this is where we do a lot of, you know, time under tension type activity of trying to understand, does someone have enough stabilizing strength and have enough stabilizing stamina? Speaking of strength, is it more neural drive recruitment? Do you have enough muscle on board? You just need to learn how to use it? Or do you need a bigger muscle? We have atrophy. I've done a circumferential measurement. You have a smaller quad. That's why your knee hurts, because you fractured your patella 2 years ago that you never got over, and you never established the right amount of size in that area. I can't tell you that people I've met in my life that have had a strength deficit or an atrophy present in their body from several years ago and failed to fix it because they never focused as long as they need to focus to actually induce that change, particularly if you're an adult. Because as we saw, we have a little growth hormone variance in us adults. Are you programming for speed and power? That's also a recruitment component. It just happens to be a hell of a lot faster. Is it more on the perturbation, reaction? Is it on elasticity of your tissue so that you activate the stretch shortening cycle amidst a speed activity or a power activity? The clearer you can get with your intent, then programming is easy. From a doctor's standpoint, it's easy for you to see change when you understand what change needs to occur. From a PT standpoint, if we don't label this from the get, or at least monitor its progress with constant updates, then our programming is a crap shot. It's a take a shotgun approach, which I used to use when I was a younger clinician, and I felt like I was growing out of my mind because I was having everyone do like every possible thing because I didn't know what I was doing. And as I got more clear on my intent, I became more focused with my language, more focused with my programming. Okay, so if we're doing slow tension, we're looking under time-based activity. If we're doing, say, strength work, we're doing more rep-based. If it's more stretching, it's, again, going back to time-based with some degree of frequency, usually daily. Understanding the frequency, duration, reps, and time and load speak the language of a strength coach and a performance coach. As a PT, we have to speak this language as well. It's not like I have all of my 65-year-old knee replacements get super structured 4 sets of 10 every other day. I don't have all of them do that, but I'm also amazed how many of them love it. Some people thrive with structure. Others want a little bit looser programming. And you have to kind of find that sweet spot with your patients. And then going back to the tools, is it going to be body weight? Are you talking with the yogi? Is it external resistance because they love their kettlebells at home and dumbbells at home? Are they a gym goer on the football team and they need to use a barbell? Do they like trap bars? Do they like pull-up bars? Do they like rings? Do they like going on hikes? I've strength trained with how people in nature going up on high logs and doing step downs off of a high log. So you need to speak the language of the person and you'll find success being in their environments trying to induce change. Going back to the variance of growth hormone, understanding the minimum dose for many, but a maximum dose to tolerance for the elite. You have to get a good gauge on this. And I think over time you develop a gut instinct of how hard you can push people, but it takes you looking at the body, looking at change, measuring change, and monitor people's success with programming to find the sweet spot of how to dose people. Minimum dose works for a lot of different types of people, namely parents, working professionals, people with really busy lives. But oftentimes people are looking for a full program, an entire program to give them, the body, the physicality, and the safety that they need. And then the last part from smart programming, when I was at UC Davis that Jenny alluded to in the intro, when I was at UC Davis, I got my master's degree in biomechanics, and all I did was study tendons because it was so fascinating. I studied tendons for 2.5 years. And I wrote a research paper on it, and it comes down to this simple sentence. All the studies of tendons, and you get this simple idea. Tendons are slow to adapt, a lot slower. And that's why when someone starts the gym program, you can almost tell, I think you'll probably get injured. If you're going to get injured, you're going to get injured not in the first 2 weeks. You're going to get injured somewhere between week 4 and week 8. That's because your muscles adapted, you got strong, but you failed to understand that tendons don't give you a good feedback loop. They don't tell you right before they're going to get injured. If you push your body to its ability from a muscular strength standpoint, you will push far capacity what your tendons can handle. And they will bark at you that evening or the next day when you strained them. And now we're on a 6-week hold because you strain your rotator cuff or strain your back. This happens to a lot of people's back and they don't know it. So letting the connective tissue, the thoracolumbar fascia, the plantar fascia, the Achilles, the patellar tendon, the rotator cuff, the flexor mass, the tennis elbow, even the deep tissue in your neck, all the connective tissue in our body needs to store energy. That's what it should be really good at. But if you haven't been storing energy there repetitively for a while, it's going to take a bit to catch up to new stress. It's just less vascular and it adapts slower. But our body's built brilliantly in that way. That allows us to jump rope a lot in 3 months and not jump rope at all for a bit. And then we can come back to it and the tendon say, hey, I'm actually pretty good at this. I can do it. If you touch tendon elasticity on a regular basis, it does hold fairly nicely because tendon cells regenerate about every 12 to 18 months. Muscles don't. If you don't do a strong thing for 1 month, your muscle tissue goes down because it's already gone through its cellular life cycle, and the next muscle cells come through and it hasn't seen shit for 29 days. But tendons are not like that. Once we train them up really nicely, we can tap into that energy storage well. But it does take a fair amount of training to build the body up, and then we touch it with the minimum dose, and we can really have a lasting effect from an elasticity standpoint. The coaching aspects, we covered some progressions, and we did a little bit in smart programming. The coaching standpoint really is about hyper-focus on their goals. You got to know their goals, their journey, their movement. We are Obi-Wan Kenobi on the Star Wars trek. We are the coach, the journey, the planner, the motivator, the cheerleader, but also the checker to make sure, no, you don't get to pass go quite yet. You have to hit my benchmark before you start jumping. But we are the journey guide. Along that journey, we give them cues. Less is more. Let the movement teach. The sweet spot of training offers insight into motor control, stamina, and strength. We have to get there safely. I'm going to show you how. The performance continuum, as some of you have seen before, is just a continuum of things that we should do early on the left and things that we should progress to on the right. Because a lot of people, once they feel good after an injury, they want to get in a hurry to something strong, something fast, something powerful. And usually what I tell people, especially if it's a non-contact injury, what I tell them is, are you stronger than you were before the injury? If not, there's a great shot you'll get re-injured. So developing a system that's stronger, better, moves better than before the injury, before the pain pattern, is a huge goal. And I'll use the phrase to pretty much all my patients, to all my clients. Through this process, you can become a different human. Better, with a stronger capacity to movement. That's it. And all of the programming and all of the adaptation and all of the influence and coaching has to lead to a change, to a metamorphosis in the human body. And it's through this left to right continuum that we do it. Now, how does that look from a movement standpoint? It's motion. Motion control then gives us the opportunity to get strong. As we get stronger, it gives us the opportunity to move quickly without hurting ourselves. As we move fast, we can work on more ballistic patterning, which we'll call power. And then developing that into a conditioned system that can handle repeat bouts over and over and over gives us performance. The reason why I overlay the aerobic conditioning on top of the movement continuum is you need enough mitochondria, enough stability, stamina in the stabilizers close to our joint centers, as well as the prime movers that move our skeleton. You also need it in your heart as well, which is why I have the systemic conditioning in there as well. If your heart's not strong with a good left ventricular pulse, and it's not fast at the higher heartbeat realm, then you're going to have a very difficult time as you get into speed, power, and performance. So recognize we need the heart and lungs to adapt. We need the local tissue at the stabilizers, at the prime movers to adapt along the movement paradigm to improve motion, the strength, the speed, the power. Now, what are the things that are going to get in our way? All the words on this tab are getting in our way. What gets in the way of motion? Tonic tissue. That'd be a fearful guard, a chronic posturing. Fibrotic tissue. That'd be scar, trauma, internal trauma, external trauma. Densified tissue. Say they've done a pattern over and over and over again. That connect tissue will get more dense to support that pattern as we see in an overhead athlete. but you can also see it, say, in a soccer athlete that lives in external rotation. So understanding what type of person are we working with, what have they done 10 million times, 10 million times, and that will lead to some densified tissue that we might have to work through to unlock. Stability and motor control feed into the motion bucket. We cannot move well if we can't stabilize our joint center and can't control patterning. This is where we do rolling patterns and crawling patterns and half of the Turkish get up and our standing dynamic warm up and maybe a little yoga sun salutation. There's an infinite amount of things to do to help someone's patterning. Stability is a lot simpler. There's only so many ways to like do a plank, hold a crawl, hold single leg stance. Super boring, but once you got it, you got it. You don't need to keep pressing on it once you can do it. Going on to strength, do we have enough tissue size? Do we have enough neural drive? And I can say the same thing for speed, power, and performance. So let's get into what programming looks like in detail. And I want to spend the rest of the time focusing on this. So let's pay attention because I have a habit of getting a little verbose. I apologize. So in programming, we first have to focus and prioritize. What does focus mean? What is the limiting factor of the person in front of us? Oftentimes there's more than one. If there's more than one, prioritize. Which limiting factor are we going to address first? That sets us up where we're at in the continuum. So we use a paradigm like the selective functional movement assessment or movement breakouts or special tests to identify dysfunction. Then we identify the status along the continuum to figure out what is our priority list and then how are we going to do it. Now, we need to schedule this. So that doesn't just mean scheduling a follow-up visit in our more like, simple life of being a PT or a doctor, but scheduling their life to how to achieve this. Is it going to be at home, in a garage, in a gym? Is it going to be daily mobility? Is it going to be strength twice a week? What can they commit to? What's needed for the body to make change, and how are they going to make that change be done? We're the scientist that gives them an idea. This is how much load it takes to get the job done. You are in control of how often to do it. We have to organize that schedule and help the person get a real answer for when will the work be done. Once we can find out the tools, the environment, and when the work will be done, then we have to look at the program itself. We have to innovate and use innovative methods. So best practice methods to achieve all this, which I'm going to go into right now. So when I say improve limiting factor, each picture is an example of a problem. The first one, here's Andrew doing a V-sit, a fascial line mobility for the adductors and medial tissue through our legs. The second picture is joint mobility about the ankle. For the first one, you should be able to open 90 degrees. So I told you we have a little bit of a lab in here. So I do want everyone to sit. Obviously, I can't see everyone that I'm seeing virtually, but I want everyone, can you sit and open up your legs in the 90 degrees? I'll give you 15 seconds to get to the floor. Create space, open up, legs 90 degrees. Okay, now I want you to draw your body up tall, very, very, very tall, chin tall. Imagine a stick that touches your sacrum, your mid-back, and your head. Now make sure that your toes are pointed straight up to the sky, 0 degrees vertical, or 90 degrees from the floor. This is a V-set posture. We should all have the medial line mobility to achieve this with a neutral pelvis that allows us to have a neutral spine and a long neck. So this would be a medial line test. Let's go into a lumbar fascial opening test. So let's see who can get their elbows to the ground. You should be able to get both elbows to the ground. That demonstrates good enough lumbar mobility. Now, some of you are saying, but Russ, I feel it in my adductors. I feel it in my groin. I don't care where you feel it. You just feel it wherever you have more sensory tissue. If you have a neutral pelvis in this position and your medial line is appropriately open, You should be able to touch the ground with your elbows. That indicates lumbar fascial mobility and lumbar joint mobility. If your lumbar can't do it, it's trying to pull your pelvis, and your pelvis cannot give anymore. All right, so that was one test. Great, you all can hop up now. That humored me for at least the lab, even though I couldn't see all my doctors online. At least it humored me. So you might as well get into a half kneel. Go into a half kneel, and can your ankle bend palms width in front of you? So you should be able to put your palm in front of your toe and get your knee in line with the tip, the end of the middle part of your palm, just like the image. That represents about 50 degrees of dorsiflexion. I'll tell you right now, I don't allow my athletes to get back to sports unless they can do that. If you can only go 20, 25 degrees, you are a torn ACL waiting to happen. I'm not as concerned about the torn ligaments in the ankle because that happens to every athlete. But if your ankle can't move well, then the next joint in line has to make up for that motion, and that's the knee. I think most athletes can deal with an ankle sprain. None of them want to deal with the torn ACL. All right, come back to the seated stuff. Let's do the rest of it. So the other skills to improve: motor control. Can you move through a pattern like the STAR excursion test that the third picture shows? Stability, stamina. Can you hold the fourth picture in a T fashion? That tests not only stability, stamina in your foot, but also in your hip and your trunk with a hinge pattern. Strength. Can you squat, push, pull, lunge, hinge according to your body weight and size? Speed. Can you repetitively jump, run, cut? Power. Can you propel an object? Can you propel your body? Can you jump? And then last is perform. When we can identify what we're improving, then the program's kind of easy. But we want to prioritize along this paradigm. We have a basic paradigm up front: pain, motion, strength, speed, power. Speed, perform. We have a more built out, detailed one that doesn't look nearly as cute, but it's more correct. More correct. Pain, starting from pain, baseline motion, baseline strength, advanced motion, advanced strength, speed, and power. Now this applies to a spine as well as lower extremity and upper extremity injuries. Meaning, I don't want you to get to an advanced motion task unless you have some baseline strength to you. This is really classic for a spine. For say someone who has an extension sensitivity and we're trying to improve how they move. We want to develop some glute strength, ab strength, core strength, even some lunge strength and back strength before we dive into the pain pattern, into the movement that is their most sensitive, into an advanced motion for them, particularly if they haven't been there for a while. But it really applies to all body parts, understanding hit baseline motion and strength first, and then advanced. And then a common question is, what is advanced? Advanced is something that they have not had for a while. Advanced is advanced for them. For the knee replacement, it's probably a lunge that mimics you going down a very high step on that involved knee for like a total knee replacement. For, say, like an elite level athlete, that might be a full bridge or a thoracic bridge. So advanced motion means different things. You have to really ask, what is the motion I want for that person, and what would allow them to be a better moving human that gets less injured in the future. All right, schedule. This is a bit of a detailed analysis of what a schedule might look like, but in the physical therapy realm, we're used to writing on whiteboards. In strength and conditioning, they're used to running off of sheets that look a little bit like the deep spreadsheet here. I think as a PT, I usually program with the whiteboard because it changes week to week on a regular basis. But if you're working with someone where they're in a certain spot in programming that they can stay there for a solid month, it makes a lot more sense to put something a little bit more complex together if they're going to stick with the same pattern, same programming throughout the month. But in therapy, oftentimes it changes, either progresses or sometimes regress week to week. So we kind of live more in the week or every 2 weeks rather than the month. Sorry, gang, I know I talk fast, but I basically try and fit as much information as possible into into these. So if I'm mind numbing, I apologize. You can blame Jenny for that. Okay, so we're going to innovate more. I want to get a little detailed on this. So if we're going to innovate with mobility, here is quotes what I use ChatGPT about 3 hours to find. I say, give me the best mobility research out there. And what does it say? It says the ideal stretching routine from Harvard Health. According to a panel of experts convened by the American College of Sports Medicine, you should spend a total of 60 seconds on each stretching exercise. So if you can hold a particular stretch for 15 seconds, repeat it 3 more times would be ideal. If you can hold the stretch for 20 seconds, 2 more repetitions would do the trick. I think respectfully to Harvard and the ACSM, this is a whole bunch of bullshit. Personally. Here's the trick. Stretch it, use the antagonist to lengthen it, train the tissue under load in the newfound range, rinse and repeat. And you could do that for everything tight in your body. Stretch it, use the antagonist to lengthen, train that tissue under stretch at a newfound range, and then repeat. So what would that look like for the classic hamstring? Classic hamstring tightness, ASLR, 45 degrees. What do? You get them on a wall, and you put the leg up on a wall while the other leg is down. So they're on the corner of the wall, one leg is up, it's say 75 degrees with the kid writhing in pain, and then the other leg is straight with obviously like the toe pointed out and the knee bent. You clean up the knees, clean up the pelvis, get the feet pointed forward as if they're running, and then they endure that pain for 20 seconds. Now, from that position, have them do 10 liftoffs off the wall with the leg up. That uses the anterior line to stretch the posterior line. Do that 10 times. Next, stand up, do an assisted T-hold. That guy, that's Evan in the upper right. Do an assisted version of that. You're going to need to teach them how to use their back muscles and their glutes to align their knee at their third toe and their back straight. You do that over and over and over again, you teach them a new skill. Now you got to do that for every part of the body that's tight. You do that, you fix motion, improve motor control, and actually help stabilize the system. Think of it as mobility, stability, motor control. And then that motor control task, the T-hold turns into the single leg RDL, a single leg hinge that then strengthens the snot out of that posterior line so they never get tight again. That's it. Regardless of what the ACSM and Harvard Health say about how long to stretch it, you could do that for 60 minutes. Now, the person might be sore for 2 weeks, but you could do that for a short period. You do it for a long period. But those are the drills they need to do to help improve the skill of understanding how to move. That's a big nut. I mean, I'd say at least like 90% of my patients have some tightness to them. I get the occasional, what's that syndrome that somehow always gets referred to me? What is it? Yeah, EDS, Ehlers-Danlos. Yeah, for some reason I collect those patients. I got like 3 of them right now. How many patients do you guys have with, yeah, 1? Okay, good. I'm glad I'm not the only one that gets. I love them because I know I'm the only one that can help them because PE sucks for these people. Strength and conditioning coaches it's very tough to put these people in a class. So they belong in our wheelhouse. I love helping them. And they're, anyways, so I get off on tangents. This is how you open up someone's body. If they're hypermobile, then you don't have to do so much stretching. You just need to do more teaching of the motor control stability task. But if they have hypertonicity, if they have hypomobility or hypertonicity, or they just don't move well because stuff is tight, you need to do this. Okay, how are you going to innovate regarding motor control? So motor control feeds into strength. So you take your motor control task or your stability task, and then you let it feed into the pattern. So this is me doing a external rotation exercise, very basic isolation exercise. I'm amazed how much like external rotation gets beat up on social media. I think social media is oftentimes brilliant, and most of the time just stupid as well. So they beat this exercise up because I don't know why. It's a wonderful exercise that fatigues your rotator cuff and lights up in your brain, as that's what that tissue is in my brain. And once it's lit up, now you teach it to do something remarkable. Do something heavy, do something fast, do something powerful. And then you'll let the lesson feed forward in something that appears more functional, more long-lasting. So the secret, do the isolated activity and then immediately follow with a complex activity. And I sandwich this all over my circuits. A core exercise and then a deadlift. Single stance exercise and then a jumping jump. Whatever. I mean, yeah, a single leg hip bridge or hip thrust, and then a squat or a jump or a run. You can get really creative here, but superset it. Okay, the phrase I want to use here for this part of the innovation is Goldilocks for growth. Your intensity and volume need to be at the sweet spots, the sweet spot of between medium hard and impossible or failure. You want to find that sweet spot, not with something heavy. You want to do it with something safe. Safe difficulty. I've never heard anyone doing a prone rolling pattern, but yet I can make it hard on everyone, as you all can as well. So our job in PT is to expose the dysfunction. We have to find a remedial task, something that they think is simple, and make them humble with, yeah, but you can't do it with great form. And for the rolling pattern, I just grab, if we're looking at Aaron doing the rolling pattern, I just grab Aaron's right heel and I rotate it. If you can get into that picture, imagine you're in that picture with Aaron, and you grab his right heel and you rotate his right heel clockwise, just a little bit, just a light touch with clockwise pressure of his heel. That'll take out his right leg. You'll keep him into a little bit of internal rotation about the right hip, and then tell him, don't push off that knee. And then you will make this rolling pattern really difficult, and oftentimes they'll cramp right in the middle of their back. And that's what you want. You want to teach the cramping lesson. And then as you free up the system and improve motor control, they don't cramp anymore. So whether or not you see a tremble, a quiver, a fasciculation, an unintentional valsalva, that would be a breath hold when you shouldn't be holding your breath, a loss of postural control, or they're sweating, doing a crawling pattern, whatever it is. So when you see safe difficulty, stay there, live there, be patient. That's our role. Find safe difficulty and improve on the system there. Okay, the next lab. Everyone stand up. I'm gonna do this one too. Okay, this is the dancer in Sambayev. This is an article by Pavel Satsaline that spoke of the power of slow twitch hypertrophy. We can enhance the slow twitch stamina building muscles of our muscle fiber type 1 in the system by going very, very slow with the pattern. So I want everyone to rotate their legs out. Your stance is gonna be a little shorter than shoulder width, shorter than shoulder width. I want you to come up on your toes so that your heels don't hit the ground. For all those on the call today, if you're on the younger side, please do it. If you have some difficulty in your knees, this is going to be a very hard exercise. What we're going to do, we're going to squat all the way down, keeping our heels off the ground. And we're going to take 60 seconds to go down. And then, but we're not going to hold there. Then we're going to come up. The going up is going to be very brutal for 60 seconds. Okay. Everyone on the virtual call, I really expect you to do this so that you are, so you understand really quickly what the role of mitochondria is in your quadricep. So slowly squat down. I am counting, and I'm just going to talk as I squat. So it's a 60-second descent. I'm going to trust you on virtual to be honest. We are going right now. So you should be a quarter of the way down. Right now, we're going to do one set. So when you do slow twitch work, it should always be sub-max intensity. In other words, all this is a squat exercise. We're just going stupid slow. You should be halfway there. Slow twitch hypertrophy is a fantastic spot to live because it's very safe on our tendons, on our joints. It's really hard on the muscle. And so we can have a great strength-inducing effect. You should be 3/4 of the way down. We can have a great strength-inducing effect with minimal threat to the body. Okay, you should be nearing the bottom. 3, 2, and don't rush up. Now we start coming up. This is where it gets tough, difficult. So we're going to go 60 seconds on the way up as I talk. So we can apply a slow twitch protocol everywhere in the body. Now it makes a lot of sense in the, oh, that's burning. We got 30 more seconds. So we can apply a slow twitch on the areas that make sense. Think the rotator cuff of the hip, the rotator cuff of the shoulder, the stabilizers of the low back, deep in the lower core, deep in the feet, in the intrinsics of your hand. How about the intrinsics of your cervical flexors? We are finishing up 10, 9, 8, 7, 6, 5, 4, 3, 2. All right, shake out the tension. All right, that was a slow twitch repetition. That was 1 rep. We could, I'm sorry, we call that 1 set. So we would do that anywhere from 3 to 10 sets, lasting from 30 to 90 seconds, primarily focusing on stabilizers, but not afraid to do it on the prime movers as well. The slow twitch protocols are essential, but they hurt. They're uncomfortable. I've met very few people in life that love these protocols. So when you give this to someone, you better have a benchmark for success, or else they just won't do it. They'll say they did it. So this is where the plank hold, the lunge hold, the T hold, it comes into factor. You have to have some benchmark of success here, or else it's hard to stick with the program because it's just super uncomfortable. I mean, imagine doing a whole workout like that. That'd be brutal. Okay, I want to share, I got 2 more programming principles, and then I'll open up for Q&A. Okay, so for the strength and conditioning metrics, it's a game of numbers. So if you're super nerdy in numbers, then this makes a lot of sense. If you're not, that's okay. I got a cheat sheet. So monthly numbers. If you hit 200 reps that are around 80% of your max, we'll call that neural drive, strength, recruitment. That's a little bit more in the nervous system than it is on muscle growth. If you hit 300 to 400 reps in a month, centered around 70%, you're going to get phenomenal growth in the tissue. What does that look like? This is cute. I saw this online, so I replicated it on sheets, on a spreadsheet. So if you're interested in strength, low rep schemes are the key. If you're interested in muscle growth, mid-range rep schemes are the key. If you're interested in power, that's a little bit more like neural drive with strength. It needs recruitment, so that's also going to favor the lower rep schemes. If you want stamina, you have to make the tissue tired. That's it. So you're going to get some hypertrophy wins if you go super low rep schemes. It's just not going to be a lot of hypertrophy. You're going to get a lot of strength gains. If you aim for hypertrophy, you'll also get stronger. But recognize strength needs to be hard. That's why you're doing low rep schemes. Hypertrophy needs to be more medium hard. And then you got to do a lot more of it to actually grow. And if I'm helping someone grow, I am measuring the circumference of their leg, of their calf. I haven't done it to someone's glutes. That'd be a bit weird. I don't really do it with people's arms unless they have a distal bicep rupture. Then I will measure their arms. It's kind of hard to do it for the rotator cuff, for the shoulder. That's weird. Yeah, I really don't do that. But I do a lot for legs. So try and have a benchmark for success so people stick with the program and you become a voice of accountability. And then the last little piece in implementing all these programming is we have to communicate. So I don't have any cute graphic here. I got a little lazy with this slide. But this is where, is it a spreadsheet? Is it a whiteboard? Is it a picture? Is it a video? I send a lot of videos to people. You have to give them benchmarks to communicate accountability. You have to identify the goals. You have to give them a timeline that makes sense. And I know this is a lot. And for all the doctors out there, I hope you realize as a PT, this is what we should be doing. And hopefully across the industry, it's getting better. But when we do this well, people change. They move better. they get stronger. If they get stronger, that means that injured ligament is stronger. The joint capsule is stronger. That means their arthritis is less painful. We can't take it away, but we can improve function, which keeps them moving, which keeps whatever needs lubrication lubricated. This stuff works for nearly everyone. Until you're ready to die, this is how we program the body effectively. But we have to be mindful of all the parameters that we influence so that we can speak the language that the person hears the best. And we affect change. Okay, for you all, break. Jenny, for your group, I'll open this up to questions, but that was my spiel, very focused on less about PT as a whole, but on programming, how to program for change. And that's what we should be doing in PT. And if you're a doctor referring to PT, that's exactly what you should expect for your patients.
Thank you, Russ. That was a wonderful presentation. Really good look at what sports physical therapists are doing and what you're doing with patients. If anyone has any questions, you can feel free to raise your hand and unmute and ask, or you can send it in the chat. But Russ, I'll just make a note that everybody chatted that the slow squat was very difficult and everybody had their legs on fire. So let's make a note of that.
Yeah, noted.
So we have one question in the chat. I'll say it out loud for the recording. So what do you recommend as physicians to consider when communicating and referring to physical therapists?
You know, most patients, I'd say half of them will do an excessive amount of research. These days is becoming more common, but they'll pressure test the doctor's knowledge. They'll pressure test my knowledge through through Google. And shoot, as soon as everyone kind of gets more clear with how to use AI, they're just going to ask AI. So I think that what they need from doctors is a strong opinion on their overall health. You know, you are the only one that can be honest with them about their life limiting factors. As a PT, we focus on movement, but it's hard for us to focus on blood because we don't see that, we don't know that. It's hard for us to focus on whether it's neurological brain health, blood health, metabolic health, organ health, and all the factors that do affect them. So when you look at someone referring to PT, you have to ask yourself, do they have the body that can successfully adapt to change? Because I think it's very difficult for PT to try and help someone change when, say, they're an alcoholic or they eat the wrong foods, or they don't appreciate or value sleep. Now, I know as a doctor, you can't get too deep into that, but you can get very deep into blood health. And so I think from one standpoint, if they have a problem that needs PT to fix, you have to ask, do they have healthy enough blood and metabolism to adapt to exercise stress? That's a tough one. I mean, but oftentimes I reverse this conversation and I say, please go back to the doctor. When's the last time they've looked at your A1C? When's the last time they've done a blood analysis on your cholesterol? When's the last time that you've spoken with anyone about your nutrition health? If that's the limiting factor that I get from that person, I'm usually pointing them back to the doctor and say, hey, I want you to develop a relationship with your doctor. I think you need more help here. And I'm getting that because, say, I'm doing an exercise and they're not adapting for whatever reason. So I think your communication is, yes, I think, if you see a movement problem, a pain pattern, yeah, go to PT to help. But I think you have to also ask, is there anything that you can do to help them be successful with PT? Because what a good PT will do to your 58-year-old with low back pain is progress them from floor mobility to a sled push to a hike. And so if that's their goal. Now, I know a lot of times we're dealing with someone's psychology here of their own habits and issues, but I always ask the person, what do you want? And then are you doing everything in your power to affect And so from a doctor standpoint, I would say, well, for the person who really wants it, for the patient who really wants to change, then I think making sure they have the metabolism and the lifestyle that can adapt to change. And then you should give them the expectation that PT will be work. I've never seen anyone become super healthy with the easiest path and the path of least resistance. So if we do our job well, we're going to put them to work safely. And if you can help communicate that they should do other things to help with that adaptation and make sure that they have a healthy enough body to do so, then we are a team. Cool.
Great answer, Russ. Thank you.
Thanks, Dr. Matthews. Fantastic. Good.
I'll go ahead and ask a question. Again, if you have any other questions, feel free to put them in the chat. But we recently had a journal club to our research group that discussed blood flow restriction, and I know that you use it and you have your patients use it. So I wanted to ask if you could talk briefly about what kinds of patients you have used BFR as a modality and the results that you've seen with it.
It's become the absolute gold standard. When someone can't use a limb, it's the gold standard to induce metabolic adaptation without threatening the tendon or the joint or just even the muscle with that much stress, because it's a metabolic stress. So by blocking blood and blocking the flushing out of metabolites, we get the muscle cell to expand. And the feeling that this very low intensity exercise is very hard, because we're not letting the muscle cells breathe, so to speak, creates this metabolic stressor that induces change, that can help grow tissue, that can help definitely prevent the loss of tissue, particularly for someone either non-weight bearing or even in a sling. So we have different methods of doing it. We can do it just with a squeeze without any work. We could do active range work, such as like a seated knee extension, or even like just an elbow flexion without any weight. And then we can follow it up with more weight or cycling or leg press or weighted leg extensions or even squats. So we can pick any exercise under the sun that's non-threatening to the tissue at stake and develop the body successfully. So it is our absolute gold standard for someone who has the mindset to do it, because it's very uncomfortable. But it's been a godsend in my world, because now I'm able to rehab right now I have a 16-year-old girl that tore her ACL, and her circumference in her leg, it's been 11 weeks since surgery, and she doesn't have any circumferential difference left to right with her calf, with her thigh, along any measure of the leg. No difference from left to right. And she had a meniscus repair that I could not weight bear or weight bear without a straight knee brace for 6 weeks. Now, 10 years ago, that was unheard of. There's no way someone would have perfect limb symmetry at week 12 when the first 6 weeks is non-weight bearing. That's you couldn't do it. But BFR allows that to happen.
Thank you, Russ.
Cool.
I do have one
Anything
more
else?
question prepared. Again,
Sure.
if anyone has anything, feel free to send it. So you work with many patients ranging from post-surgical to high-level athletes. Can you compare and contrast your approach with each kind of patient?
Holy cow, Jenny.
Just
Right.
very brief overview,
Right.
just for us future doctors.
Okay, I asked them, what do they want? And then I have to ask myself, where are they at in their life? How hard are they willing to work? And let's put a plan together to get there. I once had a 65-year-old woman with knee degeneration and chronic knee pain. And she wanted to be able to hike for 6 days straight in Antarctica. She wanted to go to Antarctica. She got some kind of special award because I guess not everyone can go there, and hike through Antarctica with knee degeneration. So we worked for once a week for 2 years for her to build up a body to be able to do that. I see pro athletes that require me 3 times a week so they can handle the stress that they need for their pro life. So you know how we do it. We have to ask, what's the goal? Now, this goes a little bit past what physical therapy is. But in reality, if you have an injury or a pain pattern, then I have a method for you to excel in your life, given the hand that you've been dealt. You know, so when you think of it from that approach, it's hard to put people in buckets, but it comes down to how lofty their goals, and that should dictate how hard they're willing to work. And then we have to put the time in to get the change in the body that we want. But I would say at a minimum, people are with me for 2 to 3 months. That's usually about the amount of time it takes to grow some muscle, grow some tendon, improve mobility, improve some skill, and become a little bit different. So now you know what to do. So I'd say the minimum level, 2 to 3 months by and large for most people. For a lot of people that really stick with the program, we get them back to a superhuman ability for their own life, better than they've ever been before. That might take anywhere from 6 months to a year. It just depends on how low we're starting. But it's less about how many visits from my end. It's more about time, because it takes time to change tissue, muscle, the nervous system. Yeah, unless you're a super adapter, like the variance and growth hormone study showed. I hope that was a correct enough answer for you, Jenny.
That was perfect. Thank you. I want to respect your time and everyone else's time. So we'll go ahead and stop the recording. But thank you, Russ, so much for speaking to us today. We really appreciate you being here.
Cool. Thanks, Jenny. Thanks, King. It was great having fun with you. Bye.